So we have the next section of patho, lung cancer, 70-year-old male smoker, COPD with lung cancer, and histopathology report saying carcinoid invading pleura and lymph nodes. So remember, what is your diagnosis based on this histopathology report? So this is small cell carcinoma. Why small cell carcinoma? So they say that it is small cell lung carcinoma because of this. Okay, so basically we have two types of lung cancer. This can be two type: small cell and non-small cell. Okay, so small cells are neuroendocrine origin, or neuroendocrine cells of a Kulchitsky or carcinoid. So that's why the carcinoid neuroendocrine. So this will be small cell carcinoma. They are very aggressive, metastasize early, and they have high chance of paraneoplastic syndrome, and they secrete ADH and ACTH. So they will got Cushing and the SIAD, SIADH syndrome. Non-small cell carcinoma has most common adenocarcinoma, and then they have the other squamous cell carcinoma, and then they have the large cell lung carcinoma. So most common is adenocarcinoma, 40% in never smoker people, and small cell carcinoma are very aggressive. They occur in like large airways. So why small cell carcinoma? Because centrally located, associated with smoking, disseminate early, aggressive, chemosensitive. What other lung cancer do you know? Okay, so we have studied this in pathology, gangrene and mesothelioma section, and I have discussed already this. So these you can tell this classification. Most common type of lung cancer is in smokers. We have the small squamous cell carcinoma, and in non-smoker we have the adenocarcinoma. But overall, most common is adenocarcinoma, which is 40%, and the small cell carcinoma, they occurs in smokers, and they also can cause the paraneoplastic syndrome of PTH, hyperparathyroidism. They secrete parathyroid-like peptide, and it calls exactly the same picture like hyperparathyroidism, primary hyperparathyroidism. What is their prognosis? So prognosis is slim from best to worse. So squamous cell carcinoma is the best prognosis, slim from best to worse. So squamous cell carcinoma, large cell carcinoma, adenocarcinoma, and then small cell carcinoma. So the small cell carcinoma, these are the most aggressive, as I discussed earlier. What are the signs of aggressive on the report? Invading pleura, lymph nodes involved, pathogenesis of clubbing. So various hypotheses have been proposed over the years to explain the physiology of digital clubbing. Some research found significantly higher plasma growth hormone levels in patients with lung carcinoma and clubbing than patients without clubbing. Megakaryocyte or platelet clusters lodge in the peripheral vasculature of the digits, release platelet-derived growth factor, and lead to increased vascularity, permeability, and connective tissue changes that are a hallmark of clubbing. So, how clubbing occurs? So, clubbing occurs because of this increased growth hormones. Okay. So these are actually the hypotheses, but they have tried their best to explain that how clubbing occurs. So one of these is that some researchers found that significantly higher plasma growth levels in patient with lung carcinoma with clubbing, and then in comparison to patient without clubbing. And megakaryocyte or platelet clusters lodge in the peripheral vasculature of the digits, release platelet growth factors, and leads to increased vascularity, permeability, and connective tissue changes that are hallmark of clubbing. So they say that in the peripheral vasculature, there is lodgement of the platelet plugs. So they derive platelet derived growth factors, which causes vascular and connective tissue changes, and this can cause to clubbing is basically the enlargement of the these fingers or peripheries enlargement. Pancoast tumor with paraneoplastic syndrome, what hormone? So Pancoast tumor is actually this small cell carcinoma. So small Oot cell carcinoma, it's also called Oot cell carcinoma or small cell carcinoma. So it causes ACTH and ADH. So it will cause Cushing syndrome and it can cause SIAD. Now the patient presents with metastasis poorly differentiated. How to tell its epithelial origin? So through immunohistochemistry. Do IHC, then you can say. If you do IHC, in this case, you will get the Kolchitsky cells or the neuroendocrine cells. What is FISH? So fluorescent in situ hybridization is a kind of, it is just like IHC, immunohistochemistry, is a kind of cytogenetic technique which uses fluorescent probes binding parts of the chromosome to show a high degree of sequence complementarity. Fluorescence microscopy can be used to find out where the fluorescent probe bound to the chromosome. Okay, so basically this is the fluorescence probe, this attached to the cells receptors, and you can say through the microscope or gamma camera or gamma probe. Okay, so 6 months later he came with back pain. Why? Because of bone metastasis. What other tumors metastasis to bone? Breast, prostate, kidney, thyroid. These can metastasize to bone. Define adenocarcinoma. So adenocarcinoma is a malignant transformation of epithelial cells that takes form of mucus secreting glandular pattern throughout the body. So remember that we have the epithelial cells and mesenchymal cells. So tumor of epithelial cell is called, malignant tumor of epithelial is called adenocarcinoma, and benign tumor of epithelial cell is called adenoma. And malignant tumor of the mesenchyma is called sarcoma. Paraneoplastic syndrome, give examples. These are symptom complexes that occur in patients with, okay, so these are the symptom complexes or these are the combination of symptoms that occur in patients with cancer and that cannot be readily explained by local or distant spread of the tumor. So it cannot be explained by the tumor origin or local or distant spread or by the elaboration of hormones indigenous to the tissues of origin of the tumor are referred to as paraneoplastic syndrome. So basically these are the complex or combination of symptoms that occur in some cancers which cannot be explained by the origin of by the hormones or the origin of the tissues of the origin of the tumor from the tissues, the actual location. For example, you have lung small cell carcinoma. So small cell carcinoma from lungs, so you cannot explain that how it's produced ADH and ACTH. So this is your paraneoplastic syndrome. So they will cause symptoms or complex symptoms or combination of symptoms that will not be explained by the exact origin and or the hormone secreting by the original tissue. So the most common paraneoplastic syndrome are hypercalcemia, Cushing syndrome, and non-bacterial thrombotic endocarditis, and the neoplasm most often associated with these and other syndromes are lung and breast cancers and hematological and malignancies. Paraneoplastic syndrome also may manifest as hypercoagulability, leading to venous thrombosis and non-bacterial thrombotic endocarditis. So, you know that cancer can cause hypercoagulable state, and this can lead to venous thrombosis, DVTs, and thromboembolism events. Plus, also this can cause the non-bacterial endocarditis, thrombotic endocarditis. Other manifestations are clubbing of the fingers and hypertrophic osteoarthropathy in patient with lung carcinoma. So there will be clubbing and the fingers and hypertrophic osteoarthropathy in patient with lung carcinoma. So Okay, we will come back to this chart later on. First, we go through this. Hormone secreted inflammatory syndrome at different types of lung cancer. So, adenocarcinoma secretes hypertrophic pulmonary osteopathy, or this causes hypertrophic pulmonary osteoarthropathy, arthrosis syndrome, and squamous cell carcinoma secretes hormonal hypercalcemia malignancy, and Pancoast syndrome. Pancoast syndrome is like it is lung, and they occurs in this at the upper top. So here we have the spine or the backbone. So this can here we have this superior cervical ganglion. So they can compress on this. They can compress on the lower trunk of the brachial plexus. So they can cause this Horner syndrome. They can cause the clumsy the Klumpke's palsy like symptoms. Okay, so these are the Pencoast syndrome. So small or oat cell carcinoma. So small cell or oat cell carcinoma is actually the SIDH, Lambert-Eaton myasthenic syndrome, and cerebral degeneration. So they can cause cerebral degeneration, Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome is actually we have this neuromuscular junction. So this is a muscle cell. This is a nerve. So here they secrete the acetylcholine are the neurotransmitter. So we have here the calcium receptors. So antibodies generated against these calcium receptors, and then these antibodies do not let these receptors to open and release the calcium for the impulse generation into the muscle. So antibodies against these are called the Lambert syndrome or Lambert-Eaton syndrome. And the other thing we have myasthenia gravis. Myasthenia gravis is the here we have the acetylcholine receptors. So antibodies against these receptors are called the myasthenia gravis. So squamous cell carcinoma is also called Pancoast syndrome, and this PTH peptide Troisius syndrome is caused by adenocarcinoma, hypertrophic pulmonary osteopathy caused by the adenocarcinoma. Yes. Okay, so define emphysema. Emphysema is characterized by permanent enlargement of the air spaces. Okay, permanent enlargement of the air spaces distal to terminal bronchioles accompanied by destruction of their walls without significant fibrosis. So basically we have these terminal bronchioles and they have the airways. So their permanent enlargement of these air spaces distal, these are the terminal bronchioles, and distal to them these accompanied by destruction of their walls and without significant, for example, there will be no fibrosis, but there will be permanent enlargement. What is the pathogenesis of emphysema? So inhaled cigarette smoke and other noxious particles cause the lung damage and inflammation, which particularly in patients with a genetic predisposition result in parenchymal destruction. So this will cause an airway disease, bronchiolitis, and chronic bronchitis. So this is actually an inflammatory disease, but a kind of allergic disease, because genetic predisposition is also important in them. So it is a kind of COPD, chronic obstructive pulmonary disease, and there will be rigidity of these air spaces walls, and they are rigid. Inflammatory cells and mediators including leukotrienes, B, interleukin A, TNF, and others, protease, antiprotease imbalance, oxidative stress, and airway infection. What are the drugs used in the treatment of lung cancer? So small cell carcinoma, tyrosine kinase inhibitor like imatinib, especially if the tumor is epidermal growth factor positive. Okay, so drugs used in the treatment of lung cancer. So we have for small cell carcinoma, we have the tyrosine kinase inhibitors like imatinib, especially if the tumor is epithelial growth factor positive. And for non-small cell carcinoma, we have the immunotherapy like checkpoint inhibitors, PD-L1 inhibitors, PD-1 inhibitor to allow T cells to recognize and kill cancer cells. Okay, so this was all about this. Here we can see the diagram, and here we can see the diagram that smoking or air pollutant genetic predisposition. So these can lead to inflammatory mediators, oxidative stress, proteases and antiproteases imbalance, and congenital alpha-1 antitrypsin deficiency. So yes, so there will be anti-protease is less and protease will be increased. So this will cause the alveolar damage and eating. So this is all about the lung cancer. I will discuss this chart in another video because my video is getting prolonged.